I'm a hematologist from Hamilton, Ontario. I was previously the president of the Canadian Blood and Marrow Transplant Group. Now it's called CTT Canada. And I was the lead author on a previous study of anti-thymocyte globulin for the prevention of graft-versus-host-disease, published a few years ago. We are now extending that study to another study for the prevention of this complication, which is has been the most important complication of bone marrow transplantation. So we've worked with anti-thymocyte globulin. Most of the advances in graft-versus-host-disease have been mostly in the treatment of graft-versus-host-disease, less so in the prevention of, although recently there has been some new drug coming along for treatment as well. But prevention, I feel, is the most important thing, best to prevent rather than have to cure. And we're dealing with two of the well-established drugs, anti-thymocyte globulin and post-transplant cyclophosphamide. Now they're now well-established, and some are favored for some situations, some in other. Anti-thymocyte globulin as well is favored in Europe and Canada and Australia, for example. Also used in the US, but less so. And the question is, number one is, which is better? This is being addressed by two ongoing randomized trials, one in the UK and one in Germany. This will take a couple of years to work that out. But both of these agents by themselves are not sufficient to eradicate, to totally prevent graft-versus-host-disease. So we thought that we should think about maybe combining the two. I mean, there are other approaches to the prevention, but we're concentrating on this particular way. Nobody knows which approach is going to work. There was considerable concern amongst my potential co-investigators because they thought that combining two immunosuppressive drugs would be too dangerous. Too much risk of virus infections in particular, and other toxicities. There had been a few small studies done that suggested that it was okay, but the investigators then agreed to go ahead, but thought that going to a phase 3 trial was too risky, and we thought we'd do a pilot trial. So our abstract at this meeting has to do with the initial results of that pilot trial. In fact, we have now got the final conclusions of that pilot trial, which is the topic of the abstract that we're presenting here. What we have done is we have taken ATG as the standard, and we've chosen that rather than having PTCy, the post-transplant cycle, as the standard, because we'd previously done a study with ATG which established that in Canada, whereas PTCy, whereas it's being used, is not, it's only been established well in Canada in haploidentical transplants, not in matched transplants. So we thought that using ATG as the standard, we're on solid ground, and we compared that in a randomized trial, with the combination of ATG plus PTCy, and we designed it as a phase 3 trial, hoping then to expand it and including these patients in phase 3. So the patients are all being followed for 2 years, though the pilot phase has endpoints only at 100 days. So the primary endpoint of this study is survival to 100 days. And we wanted to make sure with this primary endpoint that we're looking at survival to 100 days saying that we would say it would be successful if the combination drugs, combination of ATG and PTCy survival was not less than 90% of the survival in the other arm. And if it was less, we would not go further. So we did the study and found that the survival in both arms was very close to 95%, almost identical actually. The survival curves are very close. And then, of course, that would be okay if, but not okay if some important secondary endpoints, particularly the incidence of virus infections, were to be out of order in the combination. But in fact, all secondary endpoints were almost identical in the two arms. Promisingly, the incidence of acute graft-versus-host disease was a little bit less in the combination, which would give encouragement to going on to a phase 3. Now, there would be concern that maybe 100 days is too short and that calamities might occur in either arm subsequently. So we've been following these patients, and actually, fortunately and unfortunately, COVID held up the accrual in the study, as I found out a number of other studies similarly, which had to be closed down, but we kept on going and finally got our accrual of 40 patients in each arm. And many of these patients have been followed long term, and the longer term follow-up supports the 100-day conclusions that these two ways approaches were equally safe and that the combination was not unsafe in any way. And the incidence of chronic graft-versus-host disease, although not clinically significant at this stage, seems to be a little bit less with the combination. So in summary, the new combination is safe and maybe better for the primary aim of preventing graft-versus-host disease, but that will have to wait longer follow-up and more patients to conclude that. We're going to now approach our colleagues across Canada and in Australia, because Australian centres were involved in this as well. That will approach them to see if they're okay to go ahead with the phase 3, and hopefully one or two of the other centres that were too worried to go into the pilot may now be encouraged to join us.